Good afternoon, and thank you for having me here. Right, let me start by saying my conflict of interest is that I'm not a believer in minimally invasive extracorporeal circulation. However, I'm not an atheist either, so I regard myself as a bit of an agnostic. And in fact, until I joined the Hammersmith in 2010, I had no interest whatsoever. I didn't even know what a mini circuit was, more or less. I'm not sure why this moved by itself. And it was there then I met John Anderson, and I started to see what he was doing. So I became very interested because I thought perhaps there is something which is worthwhile looking into here. However, the first things I noticed was that there was a lot of confusion. And the confusion was mostly related to the fact that what is a mini bypass is how long is a string, how long is a piece of string. It can be anything you want. And you could go for something which was so minimal, which was almost dangerous, to something which was so maximum, which was like running an ordinary cardiopulmonary bypass. So since I had the benefit of having lots of statisticians and clever people, I said, can you just tell me what is being done, what is known about this field and this area? This is unpublished at the moment, but effectively the clever people look at as many as 3,500 papers. Out of these 3,500 papers, in the end, they came to the conclusion that only less than 40 were worthwhile looking. And this is the problem, because each of these papers are, in the majority of the case, a heck of a mess, because there are no primary endpoint, there is no sample size, it's just everybody's done something. However, when you take this into account and you're trying to make some sense out of it, I will just show you one or two of the results. This, for example, is any blood transfusion in relation to circuit types. And as you can see, I don't know, the one of you who are not familiar, this is called a plot in which you got, if the diamond is on this side, is favoring mini CPB, if it's on this side, is favoring the conventional cardiopulmonary bypass. So there is a tendency of a reduced transfusion. But if you want to be cynical, since you know which patient is coming who's had a mini bypass, as an anesthetist, you may decide not to transfuse him, or as a cardiac surgeon, so just to be cynical. This is complication and mortality. And again, it starts to be quite convincing, I have to say, because there seems to be less mortality, less atrial fibrillation, myocardial infarction, and even stroke. However, you have to take all of this with a pinch of salt. Now, was I convinced by all of this? Was suddenly struck by, St. Paul on the way to Damascus? The answer is no, and I'm still not. And the reason why people are not convinced is quite simple. And it is because, really, we haven't established as yet the validity of this system. Now, why is that? Why are we doing this? Now, there are all sorts of reasons, and I'll try to give you some of those. The main thing is that surgeons are very conservative. They don't like to change anything. So if you suggest you want to change somebody's clinical practice, you better have some pretty good evidence of this. And usually the evidence have to come from big study, possibly randomized, because observational study have got serious limitation, and they need to be constructed in a way that you can convince people that you've done the right type of investigation. Now, the other thing is there is also an inconvenience, because anything you do new, you have to learn how to do it. Now, in the UK, we are particularly bothered by the fact that I'm afraid we have to report the results. So each of us is very cautious in what he's doing, because there have been cases which have ended up in the newspaper, on the Sunday newspaper and so forth. So there is a reluctance, whether we admit it or not, to do anything too new and too innovative. And of course, when you do this, you need to have a situation where, as we heard, it's not just the surgeon or the perfusionist, it's a team effort. So you need to convince and bring a lot of people together. And the final thing is you have to also provide, and you're going to save some money, because at the time where, again, I'm referring to the UK, the NHS is strapped for cash. If you say, I want to use something which costs a lot more, you may find that your financial manager will not very keen on the idea. So if I had to summarize a little bit, what is the problem? The problem is in all these studies have lacked standardizations. We don't know what a mini CPB is. We don't know what cardioplegia people use, what patient were used, what the endpoint were, and so forth. So effectively, we had, and we still have in part, chaos. And out of chaos, if you want to answer a question, you have to start with some order. And I have to give a great credit to the previous speaker, Kyriakos, who is really the first guy who trying to put some order into these chaos. It's not just the book he wrote, but you heard him from him. He produced this, which effectively defined for the first time what a circuit is. So at least now we know what we're talking about, what we're referring to. And this is a great credit to him. So what is the next step? The next step, in my opinion, is a multi-center study. Why is that? Because as surgeons, generally, we are regarded as a little bit of a comic opera. This was a famous editorial in The Lancet several years ago and said, surgeons, they just tell you what is good, but there is no evidence in the majority of the case of what they do is actually being validated. And this is what we really need to do. You heard earlier on, this is the study we want to do. It's called COMEX, which is virtually conventional versus minimally invasive extracorporeal circulation in patients having cardiac surgery. Now, the primary endpoint, there have to be a composite endpoint because complication in heart surgery, not many people die. So if you look at mortality, 1 or 2%, you want to reduce it by 100%, you need 20,000 patients. So you have to find something. And those primary endpoints were taken from our study, the TITHER-2, which was one of the biggest studies conducted in this country with 18 UK centers looking at transfusion. So as you can see, we will look at mortality, MI, stroke, gut infection, kidney, severe acute kidney injury, intubation, tracheostomy, and so forth. But we also want to then look at secondary endpoint. And here is when it becomes a little bit difficult because in order to look at secondary endpoint like blood transfusion, you have to have some degree of blindness because we all been there. When we believe in something, we tend, willingly or unwillingly, not to be, let's say, honest. So if there isn't a system by which you've got criteria, if you want to prove that A is better than B, maybe in the case of A you don't transfuse, you prepare to accept an hematocrit lower, whereas in the case of B you will accept a higher one, and so forth. And this is really what is important when you're trying to design a clinical study of this nature. And also if you want to look at cost or if you want to look at hospital stay. When you look at hospital stay, the question is who decides when the patient go home? If I go around and I like treatment A, say, oh, I think he should go home, it looks good enough. If I'm, on the other hand, I see a patient with treatment B, I may say, oh, give him another day to get better. So we calculate all of this, or the clever people have calculated all of this, and come up that since the 15 to 18% was the primary outcome which he experienced with the tither, we reckon that now we're going to need, I should say, about 3,500 patients. You already saw these slides. This is what is going to be about. And we will have patients having coronary surgery, but also aortic valve surgery and a combination of aortic and valve surgery. Some units are not familiar with using this, for example, in valve. It doesn't matter. We will be happy to enroll units who use whatever their expertise is. There are some limitations, like we expect in a unit or a surgeon to have done at least 50 cases before he does embark in the study. And this, again, is the intention is to recruit about 30 centers not only, it wouldn't be possible in the UK anyway, but the idea is mostly throughout Europe, because we want to prove that if there is some benefit, is something which is reproducible, and also with some center in Canada and the USA. And again, this virtually summarizes again what I told you earlier on. We're looking at primary endpoint, but also at secondary endpoint with particular emphasis on cost. I think in heart surgery, we reach a stage where we have to do something. We have to innovate, because we're risking to be extinguished. One of my good friends used to say, if you send a surgeon and a cardiology to Mars and they come back 4 years later, the cardiology won't know where to start because it's all changed. The surgeon could start working again the following day because nothing has changed. So this is really the game, innovation. And I think the Society of Minimally Invasive Extracorporeal Circulation is given this opportunity, and I very much hope that we'll be able to get this off the ground. And if there is any center in the UK which is interested in participating, we're happy to provide you with protocol, ethics, and everything else. So please do contact me, and we'll be delighted to have you on board. Thank you.